Good morning, everyone. Welcome to today's seminar, the second part, occlusal concepts in complete denture. It will be covered under the following contents. So, balanced occlusion is defined as a simultaneous contacting of the maxillary and the mandibular teeth on the right and left in the posterior and anterior occlusal areas in centric and eccentric positions developed to lessen or limit the tipping or the rotation of the denture bases in relation to the supporting structures. Coming to the types of balance, that is unilateral liver balance, unilateral occlusal balance, bilateral occlusal balance, and protrusive occlusal balance. So when force acts on the body in such a way that there is no motion, results in balance or equilibrium. So a stable base should be the ultimate goal. In the unilateral liver balance, it's present when the equilibrium of the base on the supporting structures when a bolus of food is interposed between the teeth. It is achieved by placing the teeth so that the direction of the force is over the ridge or slightly linear. The teeth should be arranged close to the ridge and should have a narrow buccolingual width. Unilateral occlusal balance is present when the occlusal surface of the teeth on one side articulates simultaneously as a group with smooth, uninterrupted glide. Bilateral occlusal balance is equilibrium on both sides of the denture due to simultaneous contact of teeth in centric and eccentric. And protrusive occlusal balance is when the mandible moves forward and occlusal contacts are smooth, simultaneous in posterior, both right and lateral sides and anterior teeth. So what is the advantage of balanced occlusion in dentures? When a bolus of food is on one side separated the teeth so that they could no possibly be balancing contact on the opposite side. So if a bolus of food were in between the teeth for almost even 24 hours, there would not be much object on having an exact balance. But however, the teeth have contact many many times in a day in eccentric as well as centric positions with no food in mouth. And even while chewing, the teeth cut through to contact every few fractions of a second. This even pressure in all parts of the arch in centric and eccentric positions of the mandible stores the potential retention of movements when the stability of the denture is threatened by a sudden strain. The objectives of balanced occlusion is to improve the stability of the denture, to reduce the resorption of the residual ridges, and to improve the oral comfort and well-being of the patient. The advantages are the bilateral simultaneous contact help to seat the dentures in a stable position during mastication, swallowing, and maintain retention and stability of the denture, and also a cross-arch balance. The drawbacks could be it is difficult to achieve in mouths with an increased vertical incisal overlap, such in class 2 cases. A semi-adjustable or a fully adjustable articulator is required. General consideration for balanced occlusion. Now, if the ridge wider and larger the ridge, the teeth should be arranged closer to the ridge, which will give greater the liver balance. Wider the ridge, narrower the teeth should be buccolingually, which would also give greater balance. If there is narrow ridge, if and wide teeth are arranged, there will be poor balance. And we would prefer centralizing the forces of occlusion, which would greater the stability of the base. Prerequisites for balanced occlusion: all of the teeth on working and non-working side should glide against the opposite teeth. No single tooth should produce any interferences or disocclusion of the other teeth. There should be contacts in balancing side, but they should not interfere with the smooth gliding movements of the working side. And there should be simultaneous contact and protrusion. Coming to concepts to achieve balanced occlusion. First concept is the GYSI's concept, where 33 cuspal form teeth was introduced by GYSI. Now, he gave the 33 cuspal inclination to harmonize them with the condylar inclination of 33 degrees. Here, in centric occlusion, the masticatory forces are directed towards the ridge, and in the right lateral position, they are directed away from the ridge. Coming to French concept, according to this concept, the occlusal surfaces of the mandibular posterior teeth have been reduced to increase the stability of the dentures. But the maxillary posterior teeth have a slight lingual occlusal incline of 5 degree in the first premolar, 10 degree in the second premolar, and of a 15 degree in the first and second molar region. In the centric occlusion, the forces are directed buccally to the mandibular ridge, and in the right lateral position, the occlusal contact forces are directed towards the ridge on the working side. Coming to SEARS concept, so SEAR gave those channel teeth which developed a balanced occlusion by a curved occlusal plane anterior posteriorly or with the use of a second molar ramp. So in this case, in the centric occlusion, non-anatomical teeth will exert a contact force towards the ridge, sorry, and in the right lateral position, occlusal contact of force directed towards the ridge on the working side and towards the buccal side on the balancing side. Coming to Pleasure's concept, so Dr. Max Pleasure presented an occlusal scheme and called it the Pleasure's curve, in which a reverse curve is used in the bicuspid area for liver balance. A flat scheme of occlusion is set in the first molar area, and a spherical scheme is set in the second molar area by raising the buccal inclines to provide for a balancing contact in the lateral position. In the centric occlusion, the contact forces are directed towards the ridge, and in the right lateral position, the occlusal forces are directed to the lingual side on the working side and towards the buccal side on the balancing side, depending on the inclination of the second molar ramp. Coming to FRUSH concept, FRUSH gave the linear occlusal concept, which employed an arbitrary articulator balance followed by an intraoral correction to obtain the balance. Here in the centric occlusion, the contact forces are directed towards the ridge according to the linear occlusal concept, and in the right lateral position, the contact forces are towards the ridge on the working side and slightly outside towards the buccal side and the balancing side. HANAU'S QUINT. So in 1924, Rudolf HANAU presented a discussion paper which was entitled Articulation, Defined, Analyzed and Formulated. So he believed the articulation of the artificial teeth was related to 9 factors, which is the horizontal condylar inclination, compensating curves, protrusive incisal guidance, plane of occlusion, buccolingual inclination of tooth axis, sagittal condylar pathway, sagittal incisal guidance, tooth alignment, and relative cusp height. He has mathematically charted the 9 factors and listed 44 statements. And later, HANAU combined the original 9 factors and reduced them to 5, which was plane of orientation, condylar guidance, incisal guidance, compensatory curves, and height of cusps. Then Thielemann has simplified HANAU'S factors and given a formula where he says that condylar guidance into the incisal guidance upon the inclination of the occlusal plane into the cuspal height inclination and curve of the occlusal surfaces, curvature of the occlusal surfaces. Now, TRAPOZZANO'S concept reviewed HANAU'S 5 factors, and he gave the triad of occlusion, where he has eliminated the plane of orientation since its location is highly variable within the available interarch space. He also stated that there was no need of compensating curve as the cuspal angulation will produce the balance. So the triad constituted of incisal guidance, cuspal angle, and the condylar guidance, where a decrease of the incisal guidance decreases the cuspal angle, which is progressively towards the incisal angle, and a decrease of the condylar guidance decreases the cuspal angle progressively towards the condylar guidance, and vice versa. Coming to Boucher's concept, there are 3 fixed factors: the orientation of the occlusal plane, the incisal guidance, and the condylar guidance. He has confronted TRAPOZZANO'S concept, and he states that the angulation of the cusp is more important than the height of the cusp, and the compensating curves enables one to increase the effective height of the cusp without changing the form. According to him, the plane of orientation cannot be changed to favor the weaker ridges. Coming to the LOTT's concept, it was related to the posterior separation, and he has stated the laws as follows. The greater the angle of the condylar path, the greater is the posterior separation. The greater the angle of the overbite, the greater is the separation in the anterior region and the posterior region, regardless of the angle of the condylar path. The greater the separation of the posterior teeth, the greater or higher must be the compensation curve. And the posterior separation compensation curve to balance the occlusion requires the introduction of plane of occlusion. Coming to Bernard and Levin's concept, It is similar to LOTT's, but he eliminated the plane of orientation. He has named the four factors as quad, and the essentials are that the condylar guidance is fixed. The condylar guidance is fixed and it is recorded from the patient. The balancing condylar guidance includes the working condyle Bennett movement, which may or may not affect the lateral balance. The incisal guidance is usually obtained from the patient's aesthetic and phonetic requirement. However, it can be modified for special requirements. The compensatory curve is most important factor for obtaining the balance. And the cusp teeth inclines, cusp teeth have the inclines which are necessary for obtaining the balanced occlusion but are used with the compensatory curves. So the factors affecting balance occlusion are the condylar guidance, incisal guidance, plane of occlusion, compensatory curves, and the cusp. So the dentist can control only four factors since the condylar path is fixed by the patient. The incisal guidance and the plane of occlusion can be altered only in slight amount because of the aesthetic and physiological factors. The important working factors for the dentist to manipulate are the compensatory curves and the inclination or the cusp on the occlusal surfaces. So, the five factors can be related to one another on a beam balance. For example, if the incisal guidance is made steeper, the beam is out of balance. The condylar guidance is fixed. So, in order to restore the balance on the beam, it is necessary that one factor from the other side is compensated. Now, what happens to the denture? Denture balanced on an articulator that has a shallow condylar inclination setting than that of an actual patient. The denture, when transferred to the mouth, the condylar path will be steeper. There will be anterior interferences and loss of posterior balancing contact. Now, applying the beam balance beam principle, now to rebalance, we must either increase the incisal guidance should be decreased or the compensating curve should be increased. Coming to compensatory curves, the anterior posterior curve and the mediolateral curve within the alignment of the occluding surfaces of the artificial teeth are used to develop balanced occlusion. The anterior posterior curve is the curve of Spee and the mediolateral curves are the MONSON curve and the Wilson's curve. Coming to compensatory curve for curve of Spee. So it is a curve which is S projected which in the median plane which begins from the cusp of the canine and following the buccal cusps of the premolar and molar teeth continuing to the anterior border of the mandible, ending with the anterior most portion of the condyle. Now this curve is, if this curve is achieved, the posterior teeth set on this curve will continue to remain in contact during protrusion. Coming to compensatory curve for curve of MONSON, it conforms to a segment of a sphere which is of 8 inches in diameter and has the center as the glabella. Only if the teeth are said to follow the Monson's curve, there will be a lateral balance of occlusion. A compensatory curve for curve of Wilson, it runs in the direction opposite of the Monson's curve and also known as the anti-Monson curve. It contacts the buccal, lingual, cusps of molar of one side of from one side to the other side of the arch. The teeth set on this curve will have lateral balance of occlusion. So as the compensatory curves are important, even cusp height is important. So there is a case report where a 59-year-old man was a complete denture wearer for 10 years and he presented severe occlusal wear in the premolar and molar region and the decreased VD and the denture base were ill adapted. So he had a problem of persistent protruding. So they decided to make a new denture. So the first denture, what they made, they used biotone teeth and bilateral balance occlusion was achieved. So in the trial dentures, an unstable mandibular position was observed and the patient protruded repeatedly, promoting the movement of the artificial teeth. So after which a second pair of denture was made with premium artificial teeth, which had a height of 2.39 mm, which has compared to the biotone teeth, which were 1.6. So in the premium, in this trial, the patient did not perform the protrusive movements. The patient was told to wear both pairs of dentures for 2 months each. So while the patient was wearing the biotone teeth denture, the involuntary protrusion movements remained. However, with the premium artificial teeth, that's the one with the higher cusp, from the insertion to the follow-up session, the mandibular relation remains stable in maximum intercuspal position without traumatizing the mucosa. Both the teeth, the complete denture, were made at the same vertical dimension, yet the increase in the vertical dimension was not sufficient to stop the involuntary protrusive movements. According to the patient, the masticatory function and the retention with both the teeth was similar. So according to HANAU'S, the cusp height of the inclination is related to the inclination of the condylar guidance and influences the balanced occlusion of complete dentures. So the selection of anatomical higher cusp teeth, which was said as it was closer to the patient's condylar guidance, combined with the bilateral balanced occlusion, provides satisfactory results since they help the patient to maintain maximum intercuspal position and stop the involuntary mandibular movements. Sometimes, if a higher cusp are arranged, it can make the prosthesis unstable because there will be an increased horizontal forces, which can cause a residual ridge resorption, and the horizontal forces can tend to dislodge the denture. So it can be negative to the patient and should be used carefully. Now coming to a video of arranging teeth in balanced occlusion. So the condylar guidance is obtained from the patient while after taking the records, and the Bennett angle is also set according to the formula L is equal to h upon 8 plus 12. After both are set, both the components are set, we'll go to set we'll come to the incisal table. So setting of the incisal guidance table of the articulator should be within the limits of aesthetics. More closely the incisal angle approaches zero, the more stable the denture will be because of the reduction of the lateral inclines. The dentist should consider the aesthetics, ridgefulness, ridge relation, which may change the incisal guide angle. So in this case, the 12 anterior teeth are all arranged. And now they're going to do the working side adjustments. At this time, we can see that the canine hits prematurely and brings the teeth out of occlusion, and the centrals lift up. Now this can be adjusted in two ways. Either we adjust the maxillary or the mandibular teeth by grinding or by moving the tooth bodily. At this time, minimal grinding should be done. So we can either lower the canine down or the upper canine depending on the aesthetics. So here he bodily wants to move the maxillary canine up. After which he melts the wax and then he checks again for the relation. Then after the adjustment, the cusp tip is hitting the same time as the incisal area, making sure that the incisal pin is still on the table and doesn't lift up. Then in this case here, he is arranging the lower posterior teeth first. And now then he puts the upper premolar. And when he articulates it in the centric, it hits early. So minor adjustments need to be made so that the premolar is in good contact in the working position. We want to achieve as much as balancing possible during the teeth arrangement. What we can do, we first arrange the upper teeth in the curve of P, and then we modify the lower teeth uh, to get them into balancing. Coming to contacts, which we want in the balanced occlusion, on the working side, the mandibular buccal cusp ridge make the articular contact with the maxillary buccal cusp ridge, as the mandibular lingual cusp ridge are making contact with the maxillary lingual cusp ridge. On the balancing side, the mandibular buccal cusp and the occlusal facing ridges contact the maxillary lingual cusp and ridge. In the protrusion, the incisal edges of the mandibular anterior teeth contact with the lingual surface of the maxillary anterior teeth. The mesiobuccal and the lingual cusp ridge of the mandibular teeth contact the distobuccal and the lingual cusp ridge of the maxillary teeth. Checking for the occlusal errors. The technique for checking the errors is not difficult but requires the willingness to see the error. The dentist must assume that the error exists and should try to find it. So here a hand position for the test of occlusion can be done. In this, the left hand of the right-handed dentist is used to maintain the denture in position and feel the touch and slide error in the occlusion. The hand is then turned so that the little finger is up and the palm is towards the patient's face. The ball of the thumb uh, and the index finger are placed between the upper and the lower teeth. The fingernail of the other hand is placed on the lower anterior teeth. Then the patient is instructed to pull the lower jaw back and slowly until a back tooth touches. So when there is the first tooth contact is made, it will be felt by the thumb and the forefinger. If the error is present, it will feel the slide that occurs following the first tooth movement. So as the jaw here in this case at the B region, we can see the first tooth contact that can be felt. And the dotted area is the slide which will be seen following the first tooth contact, which can be felt by the fingers. So to eliminate this, selective grinding is done. Selective grinding is defined as the intentional alteration of the occlusal surfaces of the teeth to change the form. Now, failure to correct the occlusal errors before the patient wears the denture can result in destruction of the alveolar ridge, as bone in time will remodel to relieve the soft tissue. Now, errors in the occlusion can be corrected by clinical remounting or laboratory remounting. Laboratory remounting is a procedure by which the processed dentures are mounted on the articulator to correct the occlusal errors resulting from denture processing. And clinical remount is defined as a procedure where occlusal refinement is carried out on the articulator after remounting the denture with new records obtained from the patient. So if an articulating paper is used in the mouth to locate the interceptor of the deflective occlusal context, a deformation of the underlying soft tissue can happen. The denture basis can shift and give us a wrong record. The presence of saliva might prevent the articulating paper from marking the recording errors. And later, if there are occlusal errors, it can be impossible to locate or correct it because of the distorted or the swollen tissues. Methods to detect the occlusal errors: we can use articulating paper, wax template, or abrasive paste. The marking obtained can be discriminated as a proper contact, which will give a single dark spot. A light contact can be a faint smudge left on the teeth. And premature contact is when the cusp penetrates the paper and a white spot is created and surrounding a carbon ring, or also called a donut shape. Now the sequence for correcting uh, occlusal errors are followed as restored. First we restore the centric occlusion, then we correct the working and balancing occlusions, and correct the protrusive balance occlusion. So in the centric, we can have three types of errors. First one is any pair of the opposing teeth can be too long and to hold the teeth out of contact. So in this case, we would prefer to correct by deepening the fossa. In the second case, second error is the upper and the lower teeth can be too nearly end to end placed. So to correct this, we can grinding is done in such a way to move the upper cusp inclines buccally and lower inclines lingually. So the lingual cusp of the maxillary is grinded lingually, and the buccal cusp of the mandible is grinded buccally. In the third error, the upper teeth are far placed buccally. So the lingual cusp of the maxillary is made narrow, and the buccal cusp of the lower tooth is moved buccally. Coming to working side occlusal errors, here the selective grinding is done by the Bull's law. That is, the buccal upper teeth are selectively grinded and the lower lingual teeth are grinded. So in this case, in the working side, there can be 6 types of errors, where the upper buccal cusp and the lower lingual cusp are too long. So where the buccal cusp make contact and the lingual cusp don't, or vice versa. In the mesiodistal relation, the upper buccal cusp or the lower lingual cusp could be mesial to the intercuspation. So here in this case, we trim the mesial inclines of the upper buccal cusp and are moved distally by narrowing the cusp, and we grind the distal inclines of the lower cusp. To eliminate the deflective occlusal contacts on the balancing side, we grind the lingual inclines of the lower buccal cusp. Coming to a video of selective grinding. First, we analyze the occlusal plane and see if there is any discrepancy. After which the models are secured on the articulator, and then we close and we check for the lifting if the incisal plane is lifted. A separation of 2 mm is acceptable. Then we analyze the occlusal surfaces if there is any discrepancy which can cause the premature contact. Here we then use the articulating paper to double check this error. In this case, the acrylic fresh is the premature contact, which is also indicated by the articulating paper. Now this point needs to be removed carefully without damaging the adjacent teeth. Then we continue it till we get a proper then we need to restore the centric occlusion. We can do that by grinding the fossas and the marginal ridges and the cusp inclines. At this point, we do not grind the cusp tip, as this would hinder the aesthetics. The procedure is then repeated in the mandible, and it is repeated until the incisal pin touches the table in the centric occlusion. The proper contacts should be displayed onto the functional cusps, that is the maxillary palatal cusps and the mandibular buccal cusps. After the centric selective grinding is done, the working and the balancing contacts are selectively grinded. First, it is checked using the articulating paper. And the movements are made, and then we check for the discrepancy. In the mandibular anterior ear, the facio-incisal surface is grinded. And in the maxillary, the lingual surface is grinded. The goal is to have the canine simultaneously touch with the posterior teeth in the lateral on the working side. For the working side, as told, only Boole's law is used to grind the cusp as the upper buccal. After this, the balancing side contacts are checked, where you can see that there's a smooth gliding of the maxillary palatal to the mandibular buccal cusp. The procedure is then repeated on the other side until we get a smooth glide. And then we go to correct the protrusive occlusion. We analyze the protrusive interferences with the articulating paper and trim wherever necessary. After this is done, a rubber cup is used to polish all the roughened areas created from the selective grinding. So coming to a study, where the purpose of the study was to quantify the occlusal errors. So maxillary and the mandibular complete dentures were fabricated for 30 subjects. And the anterior and the posterior markings were made on the articulator and the distance was measured. So at the trial, as you can see here, the reading is 80.3, and after the processed dentures, the reading is 80.4. It concluded that the processing errors are inevitable. Hence, for the patient comfort, laboratory remounting procedure is important and needs to be followed. Coming to some review of literature, maintaining the occlusal stability by selecting the most appropriate occlusal scheme in complete removable prosthesis. This is a review article which has reviewed many occlusal schemes. So in the first one, they are comparing balanced occlusion with lingualized occlusion. So Dens conducted a study which analyzed the influence of the occlusal scheme on the masticatory performance of the edentulous patients. So 30 patients were treated for balanced occlusion for 3 months and then lingualized occlusion for the next 3 months and was single blinded. So here electromyographic measurements were made at 3 and 6 months. So this study showed that the muscle activity and masticatory performance were greater with the lingualized occlusion as compared to the balanced occlusion. And so the patients were more satisfactory wearing a denture with the lingualized occlusion. Another study which compared balanced occlusion and lingualized occlusion to analyze the influence of the mandibular ridge, residual ridge on the masticatory performance. So here 22 patients were analyzed and had one set of denture, either the balanced occlusion or the lingualized occlusion. So the masticatory performance and mandibular movements were measured at 3 and 6 months. It has been reported that in this study, the patients with the balanced occlusion developed a significant decrease in the masticatory performance. Patients with the balanced occlusion lose approximately complete dental stability and retention. And to sum up, this study said that the lingualized occlusion is greater than the balanced occlusion in terms of the masticatory performance. By contrast, another study was conducted by Butt in 2016. In his study, he revealed that the balanced occlusion has a higher masticatory efficiency and comfort compared to the lingualized occlusion. However, in the randomized clinical trial, it had only 60 participants and the follow-up of 1 month, which could have influenced the negative these findings. Overall, the results suggest that the lingualized occlusion is preferred by the edentulous patients in terms of masticatory performance and satisfaction. When comparing canine guided versus lingualized occlusion, a crossover trial was held in 2007 where 20 edentulous patients were given 2 sets of complete dentures, canine guided with anatomical teeth and the lingualized scheme with semi-anatomic teeth. Each pair of these dentures was worn for a period of 3 months, and the results showed that the chewing ability was better with the canine guided occlusal scheme as compared to the lingualized. So within the limitations of this article, the results suggested that some occlusal schemes like the canine guided occlusion. So there was a study conducted in 2012 which analyzed the influence of the occlusal schemes on the denture satisfaction and the kinesgraphic parameters. It included 50 participants, from which 44 participants received randomly the 2 complete dentures, and all participants presented a normal volume of residual ridge. Now, a denture satisfaction questionnaire was applied, and it was used to test the physiological movements during the chewing. Now, the study did not show that the occlusal scheme did not influence the patient's satisfaction and the parameters, since the volume of the residual ridges were normal. However, more studies need to be conducted in these areas. Another study by Rahman et al. Realized that the clinical single blinded study was there to evaluate the patient's satisfaction with the complete denture. The author concluded that the balanced occlusion facilitates the adaptation at the initial phase, fitting the new complete dentures. In the same context, some previous studies have been reported after the initial phase of the insertion of a new denture. Balancing contacts are no longer present because due to acrylic tooth wear, and changes in the supporting tissue. So more long-term studies needs to be done. To sum up, it appears that edentulous patients are more comfortable with canine guided occlusal scheme than balanced occlusion. However, these need to be done in larger number of participants, and more clinical details need to support these findings. Coming to a systematic review, where bilateral balanced occlusion was compared to other occlusal schemes in a complete denture. In this article, 17 studies were included and 492 patients were evaluated. This systematic review concluded that the studies indicate that bilateral balance does not confer better quality of life or satisfaction or masticatory performance or muscle activity than any other occlusal schemes. Lingualized occlusion can be considered with the occlusal scheme for the complete denture because presenting favorable results in terms of satisfaction, quality of life, and masticatory performance. Although no difference was observed between the 0-degree and bilateral balance occlusion for the masticatory performance, 0-degree presented a lower satisfaction and quality of life as compared to bilateral balance occlusion. In a recent 2021 systematic review, here 34 articles were related to the research question. So there were 3 focus questions. Does bilateral balance results in lesser alveolar bone loss? Does bilateral balance result in a more patient satisfaction, or does bilateral balance result in a better chewing ability? So the answer to the focus question 1 was anatomic occlusion resulted in lesser bone loss as compared to the monoplane occlusion. In the second question about the more patient satisfaction, literature is presenting scattered results. Some have supported the concept of improved patient satisfaction with balanced occlusion, and other literature concluded that there is no difference between balanced occlusion and non-balanced occlusion. And in the focus question 3, the literature present is weak to say that occlusal schemes can have the effect of occlusal schemes on masticatory ability. The study had conclusions saying that a dental patient with a good ridge and no neuromuscular problems will function adequately regardless of the occlusal scheme given. There is neither a strong support against or for bilateral balanced occlusion scheme, as it is related to the patient satisfaction, preference, or chewing ability. There is some support for increased alveolar bone loss with complete dentures that have non-balanced occlusion. There is a need for a bilateral balanced occlusion scheme for patients presenting with the loss of stability and retention as a result of the presenting conditions. In conclusion, complete denture occlusion is a part of stomatognathing system and not just merely arranging the maxillary and the mandibular teeth. The first and foremost concern is about the health and the preservation of the supporting structures. we need to consider factors, that is the biological, physiological, and mechanical, that favor the stability of the denture base to avoid deflective and excessive force transmitted to the underlying structure. An ideal occlusion in removable prosthodontics is the one which reduces the destabilization forces to a level that is within the denture's retentive capacity. Thank you.